So Dr. Ghosh is a consultant medical oncologist at Guy's and St Thomas in London, and she's always very helpful to the charity when we seek medical advice. So I would like to welcome Dr. Ghosh to the stage. Thank you very much. So there's a clicker on there.
Thank you.
Okay.
Thank you. Right. It's nicer to be here in person than last year when I was in between the ward round, and then the sound broke down on my side, and I think the internet broke down, and I think I'd just been asked a couple of questions, so it was a little bit, it wasn't very nice for all of you. So I'm Sharmistha. Nice to see some friendly faces, people I know from the past, and thank you very much, Deborah, and the ALK Positive charity for welcoming me back this year. It's really an honour to come and speak to you all. I feel really passionately about this charity and in general the work that we do within oncology and lung cancer, but especially for ALK Positive UK. So thank you very much for welcoming me back today. So a few months ago when Deborah and I were chatting, I think it was at BTOG, which is one of the, it's the main national UK lung cancer conference, and she'd already asked me to speak today, and she said, what did I want to speak about? But I actually said, well, what do you want to hear about? And I think, and then she asked me to talk about blood clots, which is, for me, not the most exciting. I think I spoke today, I was like, oh, I'm talking about blood clots this morning. Not that exciting. I think you've got, lots of other, the new trials, survivorship, things like that, the DVLA, but still a very, very important topic. And actually, when I started thinking about the topic, I thought, this is actually, we need to do a lot more about this. So I've learned a lot, actually, and I think altogether, this has actually been a really, really good topic to talk about. So, blood clots, thromboembolic disease, that's the kind of medical term for it. We'll go a little bit into what we're going to talk about today. So we're going to talk about the formation of a blood clot, why blood clots occur, and what that has to do with cancer. Why is it actually so important that we talk about it and consider it in our day-to-day lives? We're going to talk about the different treatment options for blood clots and how, again, that might interfere with the treatment that we're on for the lung cancer. And then what can we do going forward now that we've done all this, know about all this information? So, first of all, a thrombus. What is a thrombus? So in medicine, a lot of our terminology comes from Greek or Latin. When I was studying at school, I remember feeling really proud that I'd done my GCSE Latin, and as if that was going to make me a good doctor by knowing some of the terms. But thrombus means a lump or a blood clot, and emboli is when that actually forms a blockage within the blood vessel. So if you get a blood clot within a blood vessel, an artery or a vein in your body, that can become all blocked up, and that's when you get an embolus. And I don't know if any of you or anybody you know has ever had a blood clot anywhere else in your body, anywhere in your body, but it might then involve the nurses or the doctors in your team maybe getting the result of this on a scan, and then maybe sometimes calling you up, sometimes quite urgently, and saying, we need to see you urgently, we need to treat this blood clot. And you might wonder, well, it's, 8 o'clock in the evening, do I really need to come in right now? Do I need to come in tomorrow morning? And they'll probably advise you to, yes, this is quite urgent, we need to talk to you, we need to do some tests, and I'll explain why, and we'll all know why by the end of this half an hour. So blood naturally coagulates. When we bleed, otherwise it would just run, so there's a process within our body which causes the blood to clot up. And that's what we want. We want that. That's a natural, healthy, normal thing. The problem occurs if there's too much clotting going on in our body. And that's what happens in cancer, and specifically some types of cancer more. It's a very complicated process, and that's actually when Deborah said, can you talk about blood clots? I kind of, oh no, it's really, really complicated. I think I've left my pointer with Deborah. Can I quickly go and get it? Because it'll be, sorry. Thank you. Sorry. Whoops. I'm fine. I actually asked specially for this pointer because it's so complicated. So, sorry, this has got a little bit blurred, but when we were at medical school, we had to know this cascade off by heart. I'm not a hematologist, that's who actually deals. They are the doctors and nurses in the team who deal and help with treating our patients who may develop a blood clot. So I have forgotten all the different bits within each part of the cascade, but I had to revise again for today. But there are three components of this cascade. What we call the extrinsic pathway, this kind of purple bit is the intrinsic pathway, and then they join together to form the common pathway. And right here, this red thing here is where a blood clot forms. So there's lots of different steps and lots of different things happening, as you can imagine. There's actually 13 different factors. They're proteins that with a hematologist can test for different ones. Some of them can become overactive or underactive in some diseases, and lots of different things you can imagine, lots of arrows happening here, there and everywhere to form the final blood clot. So if something is affecting this extrinsic pathway, the main thing here, this is really blurred, but this says tissue factor, and this is a protein which is actually very important. When this is activated, this can then activate this green part here to form a blood clot. Anything in the purple sign is within the blood vessel itself. So if there's any inflammation, if there's damage to a blood vessel, then the actual wall of the blood vessel gets damaged, and then it forms a little, it can then get damaged, and all these different enzymes happen to then form a clot. So what happens in cancer? So the first thing is that this thing here, this tissue factor, very important protein that is circulating, it's within the blood itself. Some cancer cells actually have parts on the membrane of the cell that secrete this tissue factor. So if you've got lots and lots of this protein wandering around, then you're more likely to develop a clot. What else can happen? This here, this little blurred bit here, sorry, is different ions and different ions and salts, different proteins and things in the body. So one of them is phospholipid. And again, in cancer cells, they can excrete phospholipids. Another reason why you're more likely to develop clots if you've got a cancer cell that's secreting this ion. Same here. This thing here, this other blurred bit, is called a platelet. And this is something very important in this cascade, something we test for routinely when we do blood counts. We test for platelets. And when cancer is present, again, there are some cells there that can excrete more and more of this thing here, platelets. Another reason why we're going to get more blood clots. And up here, this I was talking about the blood vessel itself and the wall perhaps getting damaged. So any kind of inflammation, doesn't need to be cancer, but any kind of inflammation or stress in the body is going to cause that blood vessel, the wall of the blood vessel, to break down. And you can imagine then that will then set off this cascade, and again, more likely to form a clot there of blood within the vessel. So all these things, these four things, is more likely why we are more likely to develop a blood clot if there's cancer present in the body. And then the thing in the human body is then this cascade itself, all these things itself, are actually really, really a good thing for cancer. So cancer cells can help cause these bleeding, coagulation, clotting processes. But the whole thing itself is actually what cancer cells like. So if this is overactive and we're developing more reasons to develop a blood clot, the cancer cells themselves thrive on the blood being nice and sticky and thick. So it's more likely here to cause development of this protein here, other things as well. One of these proteins here that causes stranding. And in general, I've just put a big red thing. This is for cancer cells. They're like really going to proliferate. They're going to grow. They're going to really enjoy this kind of environment. So it's almost like a vicious cycle. It's helping to cause the clot, and the clot itself is quite a nice thing for the cancer cells to thrive and grow in. But we want a little bit of blood clotting, right? We can't have runny blood all through. We need the blood to clot. That's healthy. So it's getting the balance right that is where it becomes even trickier and difficult. Not difficult, but tricky, and something to consider for doctors and nurses, oncologists, but hematologists as well. And it's really important to have them working with us. So because of all the reasons we've talked about nowadays, when we're talking about blood clots, about 1/5 of all people who have developed a blood clot will have had cancer at some point. So it's quite a high, proportion. 1/5 of all blood clots will occur in patients who have had cancer. And as we say, knowing that if there's a blood clot and blood clotting too much and blocking off blood flow within the body, that can be quite a devastating thing for many patients, especially if it's not treated appropriately. And we can talk about the symptoms and how we can detect that later on. We've talked about how cancer interacts with that whole clotting process and how it is very difficult. Now, the insert of this CAT is cancer-associated blood clots or thrombosis. Worldwide, it's increasing. And why is this? It's probably actually because we're detecting more cancer. People are living longer with or without cancer. Our treatments are getting better, not only for the cancer, but for the blood clots as well. So some people are actually developing another blood clot after they've already developed one blood clot. So it all becomes very complicated again, but the basic message is it's not decreasing. The incidence, the number of blood clots that people are experiencing is actually increasing. And this is the world over. So this also takes into consideration countries that are maybe not as developed as the UK or in the Western world. So that's something else as well to take note. In other countries who are now really getting involved in clinical trials, such as India, for example, 10, 15, 20 years ago, they probably weren't reporting cases as much. They didn't have as good kind of data and able to participate in as many trials. So they're all kind of putting all their numbers and figures in. So overall, if we kind of take a step back, we're seeing that the number of blood clots overall in the world is increasing. But it's many, many factors that are causing that. And because of that, we are now getting many, many different anti-blood clots, so blood thinning medicines that are going to help us. The other thing is that, as you have heard about yesterday, you're going to hear about for the next couple of days, we are getting better, thankfully, in treating cancer and lung cancer. So there are many, many new treatments that are now becoming available, that we're testing in clinical trials. Some of them can have likelihood to sometimes cause an issue within that very complicated coagulation cascade that you saw. So when a blood cancer therapy is started off and we're doing it in clinical trials, lots of rigorous testing goes through in the early phase of the trials to see how it affects that really complicated process. Because if we can, we want to try and avoid the development of a blood clot whilst we're treating the cancer. So these are the risk factors for if somebody, what we are thinking about in our day-to-day work. We think, okay, I have a patient who has cancer. How are we going to work out if he or she is more likely to develop a blood clot? Because it's not like 100% of patients who have developed this are going to then get a blood clot. Is there any way that we can kind of try and predict, maybe we're a little bit more worried about this patient, we're not so worried about this patient, and try and have a little bit more understanding about what is going on? So we've split it here into 4 kind of different groups. So first of all, the type of cancer itself. That can be quite telling. Now, not a lot of data. When I looked through data and when I was kind of learning, let's say 15, 20 years ago, I was told, we learned that cancer such as pancreatic cancer, stomach cancer, lung cancer was listed in there as well. They were the most common cancers in which we were, going to think, oh, we're worried here. We need to think about a blood clot. But actually moving forward now, and again, because our treatments are so much better, breast cancer, prostate cancer, and lung cancer. These are the 3 cancers in general in whom we start to think we need to think a little bit more here about this group of patients. And that is because, you know, we're doing so much better in treating these cancers. Not to say that the other cancers we ignore, that a blood clot could happen, but these are just, you know, things that we're a little bit more considerate in our clinics when we're thinking about it. Then histology. So that is the type of cancer. There are many different types of cancer, as you know, and there are many different types of even lung cancer. And in general, the cancers that are a little bit more aggressive, the ones that we're a little bit more worried about, they tend to be the cancers that we consider are a little bit more risky in the development of a blood clot. And that goes as well with the grade. So if something's a bit higher grade, it's something that we're a little bit more considerate of. And the initial period, so at the time of diagnosis for many people, and not for all, but for many people, at that time when the diagnosis is just happening and things are not quite certain, that can be a time that a blood clot can be diagnosed. It's not that uncommon for it to sometimes be that the reason that people maybe go to hospital is because they've developed a blood clot, and then actually when all the investigations happen, the underlying thing and the reason that the blood clot was even there was because this cancer had been present. So this is something that we think about when we see our patients. And then what about the treatment? I don't think my amazing thing is not working, but the treatment-related box on the far right. So whether any kind of treatment that we're giving patients, does that actually increase the risk of developing a blood clot? Because if so, well, we need to know about it, and do we need to do something about that? So we know that any type of surgery, regardless of the patient, any type of surgery can increase the risk of developing a blood clot, especially surgery that happens kind of in the lower abdominal area, the legs, and that's just a standard thing, regardless of if I was speaking with you today at this conference. So if anybody is undergoing surgery, we usually will make sure that we give some blood thinning products so that the blood is a little bit thinner before you're going into surgery. The same for some kinds of procedures as well. And this is with or without. Sometimes we do a procedure and we take a sample of tissue maybe. Even if we're not taking a sample of tissue, if we're going to do a procedure, it's again something that we'll think, well, we might just want to make sure the blood is thin, but then not too thin for if we want to take a sample of tissue. So again, it's a balancing act as to how we do that around the time of the procedure. Chemotherapy has been known, and this is kind of maybe not so much the tablets that some of us may be taking, but chemotherapy, some of the tablets as well, they have been known to increase the risk of a blood clot. And anti-angiogenesis, that's another type of medicine that we can use in some types of cancer that alter the blood supply of the actual cancer. And they, again, can be known to increase the risk of the blood becoming sticky and causing a blood clot. So there's lots of different things that we think about with or without the treatment of cancer or the presence of cancer. These are biomarkers, so these are things that we look at in the blood when we take a blood count. We look at different things within the blood, and if these things are quite high or elevated, which they can be anyway, they can sometimes put a little bit of a hint as, oh, we need to be a little bit worried here because all these kind of markers, these proteins, these markers in the blood are a little bit high. So these are things that we're looking at regularly, very, very regularly. And then what about patients ourselves? Is there anything within us that makes it more risky for us to develop a blood clot? So the more elderly somebody is, the more likely that they are to develop a blood clot. Ethnicity actually does have a role to play as well. So in studies that have been done, again, worldwide, patients of African American descent have been the most likely to develop a blood clot. And this was in more American studies that were done, but that's the most common group of patients, followed then by white Americans, because it was an American study, and then the least likely group were patients or people of Asian descent. And again, we don't know what within the blood, what in that coagulation cascade. There's not been anything that we've been able to pinpoint that any of those 13 different factors in blue and yellow and green boxes are more increased, that something is going on there. Now as well, in the world, it's a small world, right? There's lots of travel, lots of diversity in the world. So is there anything in the environment that we're living in? These were all the main studies I looked at and that we have are again studies done in the Western world. And usually the mix of patients is very varied. It's not just one group of patients. So we don't know how much the environment where somebody was brought up and then moving to a different environment, how much that has to do with things. I did look specifically about air pollution because I know this is obviously a very, very hot topic. We know that smoking does definitely increase the risk of a blood clot, and there's not been anything pinpointed to suggest air pollution does, but I think that's just because there haven't been any big studies to actually demonstrate that. But I think, I don't know, I use my common sense and probably think, I don't think it's a protective factor if you're living next to a factory that you know, that think, oh, I'm safe from developing a blood clot. So I'm sure there will be much more, and there will be much more evidence and data going forward to look at all these specific links within our environment. And comorbidity, so that's other medical conditions that someone may have. So if maybe somebody's kidneys are not functioning as well, that's the risk of developing a blood clot, and liver function as well. The liver is actually a part of the body where a lot of the coagulation and the blood clotting takes place. So if that's not working as well, we are worried about that as well as a risk. Okay, so those are the two kind of main nitty-gritty slides. Talking more about now life and everyday. What we talk about, there are two types of blood clot we usually say. Some of them are incidental. So I don't know if anybody has experienced where you've maybe had a scan done, and then, as I say, you might get a phone call from somebody in the team saying, oh, there's a blood clot that we found. Would you be able to come back to hospital because we want to give you a blood thinning medicine and just check that you're okay. And that's because quite often the blood clots can be so small that patients, we don't feel anything, and we're actually, you know, wandering around our daily life and we don't actually get any symptoms. And that usually, but not always, can mean it can be quite a small blood clot. But I have had some cases where the blood clot's been a little bit bigger, but the patient doesn't have any symptoms at all. And that's what we call an incidental blood clot. So we ourselves have picked up that blood clot as an incident. We've been looking for other things, and at that same time, we found a little blood clot that we can see on the scan. I didn't put any scan pictures here because I really am not very good at picking up blood clots on a scan. We'll always have to go. I'm not a radiologist, but really I find them quite difficult. Many doctors and nurses find it quite difficult to pick up. You have to follow the blood vessel through, and I would have been pretending to kind of show you things. So I didn't bring a picture on purpose, and certainly not an incidental one. Symptomatic ones are where patients might actually come in and say, or if we ask our patients, you know, I have symptoms. And usually if it's in the leg, so it's quite common in the leg, even in patients who are, you know, without cancer, are traveling on a long flight, not moving around, and the blood flow is just not occurring smoothly enough up the leg. And it's usually a red, hot, tender leg, can get quite swollen. Usually one, not both sides, because usually it's in one side. If it's in the chest, if it's in one of the veins that are supplying the lung, then it can be sudden shortness of breath or pain. And usually the pain is when you take a deep breath in. So you may have had your medical team asking you if you take a deep breath in, does the pain catch your breath? Because what's happening there is as you're breathing, you need more blood flow to the lung, and because there's a blockage there in the vessel that's helping with the lung, you're not getting that. So that's why the lung is not able to expand, the blood flow is not adequate to that part, and you can get that sharp pain. It's not always like that, but that's the common way that it can present. And then if we test your oxygen saturations, they may be quite low. You can get lots of developments on from that further that can be more and more risky. if it's a very big blood clot, people usually will know about it or will not feel that great and let us know, or we'll ask. And that needs urgent treatment with a blood thinning medicine, which we'll talk about. So the PE is what we call a pulmonary, an embolus that's in the blood supply to the lung. That's very common. And the DVT is a deep vein thrombosis. So usually in the leg, sometimes in the arm as well, but usually in the real deep veins in the leg where a clot can form. Sometimes they can form in quite unusual sites, especially with our group of patients. We have lines done. Patients may have had lines put in for either receiving medications, and they can sometimes get a little bit of blood clot within the line itself. So I don't know if any of you have had a line, and then you need to have it flushed regularly, every week usually, by the nursing team to prevent a clot from forming. So there's lots of, it can occur anywhere in the body, but lots of things that we do to try and prevent a clot from forming. So I specifically wanted to look at ALK lung cancer and whether there's any kind of link between ALK lung cancer and the development of a blood clot. That's what we're here today to talk about. And this is where I found, gosh, there is some evidence, but in my opinion, not enough evidence, and I got quite frustrated. So there was a large cohort study. A cohort study is where a group of scientists have to take lots of studies and pull all the information from many studies. No, a large cohort study is where they're in one place and they've got many different patients over a period of time, and then they pull all the information together, and it's just looking at one specific group of patients. So the Cleveland Clinic is a big American research department, and they did a cohort study of 461 patients with cancer. However, this is what got me frustrated, only 46 patients actually had the ALK lung cancer. So only a tenth of patients were, for me, was interesting for me to look at. But interestingly, in those 46 patients, almost half of the patients had developed a blood clot, and that was much more frequent than all the patients without the ALK lung cancer. So you don't want to be, kind of rush into things and say this definitely means that patients with ALK lung cancer are going to develop a blood clot. It means that we need more work done on this, but something that we do need to think about. Now, this study took 15 years, so they looked at all patients in this centre from 2002 all the way through to 2017. And in this time, they only managed to get the data of 46 patients. This is not that helpful because, as you may know, we've only been recently doing lots of research, treating ALK as a separate kind of disease. So I think as time goes on, this was now already 8 years ago. If we do something from 2010 to 2025, there'll be many, many more ALK patients there, hopefully. But this is what had been published, and the biggest one, because 460 patients a lot, I got really excited. And then when I saw the 46, I thought, okay, it's not going to be amazing data because it's such a small number of patients, but still something to think about. Now, smoking is known as a big risk factor for the development of a blood clot. And that's quite interesting because, as we know, smoking is not a risk factor in development of ALK lung cancer, right? Many of us have not smoked or have smoked very, very little. So is that telling us that the ALK lung cancer, something is happening which is even stronger than the smoking thing? They just don't match up. So there's just telling us that there's a lot there we need to do. They hadn't actually been able to give us a lot of data in this group here. We know that 71% of these patients in this 46 had not smoked. So we know that it was not any part in the development of the lung cancer. We know that as well in the ALK patients that developing a blood clot in the legs was more common than developing the blood clot in the lungs, which I don't know if that surprises anyone, because if you think if you have the cancer in the lungs, would that not be more likely that you develop the clot here? But it was in the legs, that was more common. So another review, and this was a big systematic review, that this is a British thing. It was published in one of the British medical journals, and this is more recent because it was only published a couple of years ago. And it looked at different trials done, not just in the UK, all around the world, with patients with ALK lung cancer, prior to 2023, and then they published the data. And they looked specifically at whether the medications that we're prescribing for the cancer, do they have any increase in the incidence of clots? Because if so, we need to know about it. Is it something that we need to prevent? Do we need to be more proactive? Now, the conclusion of the trial stated that they weren't able to give a very good confirmation. They stated that one of the medications, crizotinib, which we're not using that much, could play an increased risk in developing a blood clot, but they couldn't comment on any of the other ones. Again, it wasn't very many trials. They only had 8 big randomized trials that they looked at, and there were many confounding factors. So lots of different things that they stated in their conclusion that they had to state, well, we can't really give an accurate conclusion because of all the different things. But certainly food for thought. And certainly I was happy to see that at least something had been published telling us that we need to do more work into looking specifically at the medications themselves and whether they could be at risk of a blood clot occurring. So what kind of options do we have for stopping a blood clot? How do we thin the blood? We want to prevent the clot from worsening, so we don't want the clot to actually get bigger, we don't want it to grow, and we don't want it to travel around the body to within the blood supply. So it's essential to prevent a big clot from forming. And when we give a blood thinning medicine, what we're doing is we're actually dissolving the clot, but actually quite slowly. Once the clot once the blood has become clotted, you don't want to give a very drastic medication, because then the clot could break off and you could get lots of little smaller clots flowing through the blood. So you need to be really careful, and you want to just very slowly almost and smoothly break down the clot so that the blood just kind of dissolves, the clot dissolves, and you've just got smooth, blood flowing nicely. So that's something you need to control. And the big risk as well is bleeding. If you're giving a big blood thinning medicine, you don't want the blood to become too runny and then start to cause bleeding episodes in the body. So it's a balance, looking at that cascade and all the different medications, how long the medication we should give with the blood thinning. That's within the body what we're thinking. And then on the other side, we have to think about the patients. When we're wanting to dissolve a clot, as I said, it takes a long time for the blood to become less sticky, for the clot to dissolve. And it can be a real big burden. Some of the tablets that we are giving patients, many tablets in addition to all the other tablets that patients are already taking. So that's something we need to be aware of. And the other thing many people may have been on is the injections that we sometimes have started people on to thin the blood. That can cause lots of bruising. We actually tell patients to use the injection every day, sometimes for a period of many months. And I've seen patients coming in with quite bruised areas. We're saying, oh, you can move around where you're using the injection, but it's really, big bruising and pain in that area. So we really need to see how are we impacting the quality of life here. We want to treat the clot, but we need to do it in the way that's as tolerable as possible, but also as safe as possible. So you have to balance it on both sides. So warfarin is a medicine which we were using many years ago. It's not as common to use now. The reason it is not as common to use is because of the regular checking. So when we use warfarin, it takes at least 2 days for the blood to become thin. So if I give a warfarin tablet today, I'm not actually going to see the effect of it until probably Monday. So if I give a tablet, I then have to ask the patient to come in again on Monday, do regular blood checks. Patients were coming in and out of hospital to get a blood test, to be pricked again, and then we would have to alter the dose of the tablet. It was really a lot of pressure on the patient to come in. There was a high bleeding risk as well in general with warfarin, especially with patients. We were using elderly patients with this warfarin. If they maybe hit their head, we were seeing that there was sometimes some bleeding occurring in the brain. This is not in patients with cancer. This is just normal, this is just patients even without cancer. So in general, we knew 10, 15, 20 years ago that there had to be other options. We still use it, but it's not as common because we have other newer medication. So low molecular weight heparin is the injection type of blood thinning. And it's been the standard of care really for about 10 to 15 years now. over this warfarin medication. The downside is it's an injection, so you have to have the injection every day, sometimes twice a day, depending on the dose that you need. But the upside is it doesn't take so long to monitor. So once you've started the injection, you're already knowing that the blood is being thinned, the treatment is started. You don't need to come in again 2 days later for another blood check. It lasts for a bit, the effect starts sooner and lasts for longer. So it's a little bit easier to control, so if patients don't have to travel in and out of hospital very regularly. When we did not me myself, but when a comparison was done between that warfarin tablet and this injection medicine, there wasn't actually much of a difference in bleeding though. So that risk of the blood being too thin was still there. So then we knew we had to see if there were other medications we'd had. So it's a good medication, perhaps better than the warfarin for reasons we've stated, but actually be better if we could get newer medications. And patients were crying out for if there was a tablet medication so they wouldn't have to have these injections every day. So these are called direct oral anticoagulants. They're called DOACs. I don't know if any of you have seen this as an abbreviation. And these now is what we are using in the UK, generally in most places as a first line, the first type of treatment for if a blood clot has occurred. The reason this is better is no injections. So it's a tablet medication, and in comparison to that warfarin tablet that I was talking about 15, 20 years ago, the bleeding risk is not as high, and it's easier to control. So you don't need to come back into hospital every couple of days for a blood count to check that your blood isn't too runny or not runny enough. So much less monitoring required. You can take the medication and you can go home and you know that the blood clot is being treated. However, I again got a little bit frustrated because I wanted to look in detail about these direct new tablets in patients with cancer. And I found out again that patients with cancer were underrepresented in these trials. So these trials are big trials, but most patients, many of them didn't have cancer. So it kind of leaves my group out a little bit. So this is one of the most famous, these two blood thinning trials that the hematologists now kind of refer to. This here, the one beginning with R, this is one of those tablet direct medicines, the new ones, and this is the injection medicine. So it compared the two together. And 58% of patients had cancer. The rest of the patients didn't have cancer. So it was good, but I would have preferred that there were more cancer patients in this trial so that we could use the data for my patients. And I just looked specifically about what type of cancer, because as we know that can differ, the risk and the incidence of a blood clot. Quarter of the patients had colorectal cancer, and then these were just grouped together in order of the highest incidence. So quite helpful, but I would have liked the cancer patients to be more represented in these trials. In many clinical trials, especially like this, when the sponsors, the trial designers are setting up a trial in the past, they would have said that cancer patients would have maybe been excluded from the trial because it's so difficult and can be so tricky for the reasons I showed you in that big coagulation cascade. So to get a quick trial done, they've excluded cancer patients. It's not helpful for us at all. Getting better now, 58%, but still. And this trial as well, this other one again done 7 years ago now, only half patients had cancer. So it's good, I can still use the data, we can still talk about it, but we just have to bear that in mind because things are a little bit different, as I've explained. This is a very big trial done just 3 years ago, and this again compared another tablet, one of the new tablets, against this injection. And this is what I was talking about, they actually excluded many patients who had cancer. So these are two types of skin cancer. Any patients who had a primary brain tumour, any patients who had brain metastases from any type of cancer, and any patient with acute leukemia. So they're immediately taking a whole host of patients in whom we need to know, we need to get the data. So this angered me a little bit, but it's the way things are. But at least we can look at the data, but we need to get more trials for our patients. So which medication should we use and for how long? This is the big kind of discussion now. And again, just to show you how different things are, these are recommendations from 4 different hematology or oncology groups. So NICE, as you know, is our authority in England and Wales, and this is in 2020. They're saying to use a tablet medication, as I said. But this is the European Society of Cardiology. They're actually saying to use the injection first and then perhaps to consider the oral tablets. So that's in contrast to what NICE are saying. ASCO is the American Oncology group, and they are saying to use either the injection or the oral tablets. They're basically saying not to use, this is the warfarin. So that's what we would do. But a little bit, they're kind of contraindicating themselves slightly. And this is the hematology and thrombosis group in 2018, and they are saying to use these tablets. So if you put all together, they're roughly saying the same thing, but none of them are actually saying to us, this is what you should use. They're not 100% all kind of coordinating together. So it's difficult, it's tricky. So we talked a little bit about challenges to anticoagulation, blood thinning, and just to go over it again, kidneys and liver, they are the 2 parts of the body where these new tablets are processed. So if we have any issues with the kidneys or the liver, either due to kidney disease, maybe the medications we're taking, blood pressure medicines can affect your kidney. So if you're already taking blood pressure medicines, what's that going to do to the blood thinning medicines? So these are things as well that we always think about before we prescribe one of the medications. And extremes of body weight. So if someone is very, very thin, or if they're a little bit heavier, then that can also affect how the blood thinning medication is processed in the body. I talked a little bit about bleeding. That's one of the big risks of the blood thinning. We want to thin the blood, but we want to make sure it's not too runny, because we want the blood to be, as you know, in a healthy way, it's clotting. So again, it's how much clot is there. If it's a small clot versus if it's a big clot, do we change the dose of the anticoagulation, of the blood thinning? How long do you give the blood thinning for? If it's a very small clot, maybe you can get away with a couple of months of the blood thinning versus a big clot where you might need to be on the blood thinning for even a couple of years. How long are you needing to be on your cancer medication for? Does that have an effect on the blood thinning? And the need for procedures I talked about. If you're going to have surgery, we know that we will want to thin the blood a little bit because the blood is going to get a little bit stickier. However, if at the time of surgery, they're going to maybe do a procedure, then you don't want the blood to be too runny. So again, it's balancing everything. And then how long will the treatment last? Because the blood thinning can last for different lengths of time, depending on different parts of the body. For example, the kidney and the liver. I'm going back to this trial because I wanted to just show you about, another risk that I haven't talked about is recurrent blood clots. So we sometimes can get very reassured that we've treated the blood clot, everything's fine, we can be relieved, the blood is of a nice consistency, but then there are some cases in which patients are getting another blood clot whilst they're already on their blood thinning medication. What's going on there and who are more at risk of this? We still don't know, something we are always looking at, but we looked here, this is the new tablet and this is the injection. So this graph here is looking at the chances of patients developing another blood clot when they're already on their blood thinning medicine. This dotted line is the injection one, right? And this is the blue line is the new fancy tablet medication that we're now recommending to use. And you can see here, this graph is the number of recurrences of the blood clot. So patients who are taking the injection medication, they're more likely to have another blood clot on top of the blood clot they already had whilst they're taking the medicine. So this is another reason why we prefer nowadays, not always, but it's a reason why you might be swayed to use the tablet one over the injection one, because you don't want to then have another blood clot when you're already thinning the blood. And then we looked at bleeding. So this is if the blood is just a bit too runny. And there's not much difference. You can see actually, again, the dotted line, the red one is the injection, and this is the tablet, the new tablet. And actually, they're much and such the same. And we did say that before, that the risk of bleeding is actually much the same between the two medications. So that's reassuring. I'm going to just go relatively quickly because I know I'm pushed for time and I don't want to interrupt the coffee break. But the drug interactions, that's something that we talked about. How does it affect patients? Very important, so I do want to spend some time on this. I think a lot of us think, and in our clinics, that once we've treated the blood clot, they maybe don't have much of the way of side effects, but that's actually not necessarily true. I think because we were using the injections a lot in the last 10 years, when these new tablets came into the fore, we felt better because we thought, well, we're not using the injections, patients will tolerate the tablets better. But they're tablets, and they also can have significant side effects on how patients feel. So quite a few people have come back to me and said they feel quite sick, and it's not the cancer tablet they're taking, because they've noticed since taking the blood thinning medicine that actually they're feeling sick, and in some patients they've even been vomiting. And that's not nice at all. We need to be on this medication maybe for a length of time. So this is something to think about. And in patients who've had surgery, so maybe not so much within anybody here today, but if you've had surgery, maybe in the stomach or in the colon, they really have been affected with taking the oral tablets. And anecdotally, I've had many patients coming in and saying they really don't like the oral tablets because of how it's making them feel. That might be then something that I would discuss with my colleagues in hematology, and maybe those patients would be better off for them being on the injections. They're not nasty for everybody. And some of them can be relatively big, but in patients who really don't like swallowing, it's something to just take note. If you've already got loads of other tablets, is it actually the right thing for that person to be on another type of tablet for the blood, for the blood clot? This is talking about the absorption, about the fact that you need to, with the different tablets. So what can we do as a group? Why did I get it? At the beginning, as I said, I kind of thought, oh, blood clots, that's a bit boring. It's not that exciting. But actually, there is a lot we can do. I found out when I was looking into this and reading this that we have not really got very much. We don't have a load of massive wealth of evidence, especially for ALK lung cancer. So first of all, within just day-to-day practice, within the hospitals, we need to make sure that we've got really good working relationships with our hematologists. Medicine now has become quite focused. So even oncologists, we treat maybe different types of tumor, and I'm a specialist in lung cancer. I don't know the most up-to-date evidence for skin cancer, not something that came out yesterday. Similarly with the blood clots, I had to do quite a little bit of research, my own research, just to find out what exactly is the best, where is the evidence. So the hematologists are very specialized in this, and they are similar. They have a blood thinning team specifically trained to specialize and look at all the different evidence. But we need to make sure that we're just kind of reminding them that we are very important as a group, and they need to put a little bit of, I don't want to be mean to them, but they need to do a little bit of work in looking specifically for patients with cancer and what they can do separately and specifically for them. Most big hospitals will have, and small hospitals will have a special bleeding team, but make sure that there's lots of work and studies and literature and things we can do together to get a little bit more understanding. At the moment, because of all the issue, number one, not having enough evidence, number two, it's being such a complicated subject, we are not yet advising that we would prophylactically treat a blood clot. So nobody yet is saying you have to take this blood thinner to prevent a blood clot, but it might be something that is happening in the next few years. And the only way we'll get to that stage to actually determine if it's the right thing to do or not is to do more studies and have cancer patients very heavily represented in those studies. So this is just a copy of what we use at Guy's, just to how complicated it is. This is the guidelines that the haematologists have written specifically for our patients, for our cancer patients. Just relatively new. We update this every year, and this is just telling us how to treat. So, and for us, as I say, talk about your symptoms. If your doctor or nurse doesn't ask you when you come to clinic about pain in the leg, about pain in the chest, don't feel frightened to say, do you know what, this is not quite, I feel different. I feel that there's a bit more pain here. Could this be a blood clot? It's not a big test to have a scan of your leg just to check. Be aware of the symptoms and be an advocate for that, and don't feel frightened for just asking the question if you feel that it's something that you might be experiencing, because it can be treated, and it's good to have that kind of relationship with your team. That's it. I hope that was cool. We have time for questions.
So we've now got the opportunity to ask Dr. Ghosh any questions that we have. So please take this opportunity. So does anybody have any questions? We have a roving mic around. Here we are, we have one here.
Hello. Hello.
Hi.
Hi. You haven't mentioned anything about what we can do other than ask the questions and report the symptoms, but I would imagine that staying hydrated and staying mobile are paramount in helping to reduce your risk of thromboembolic disease.
Definitely, and I did not say that, and I forgot to, so thank you, that's really important. So yeah, there are practical things. I get that question a lot, just even day to day, for can I go on a long flight? You can go on a long flight, but yes, staying hydrated is a big thing. You can drink alcohol, but alcohol is a risk factor just in keeping the blood a bit, I say sticky, just to kind of help in my mind think about a blood clot, but becoming a little bit more at risk of developing a clot. Movement is really important, and even like the exercises, kind of flexing and your foot up and down. If you're on a long flight, moving up and down, just even standing. So standing helps the valves in the legs, so with the blood flowing up. So even just standing on the plane rather than sitting in the tight seats can help. Pretending to go to the toilet a lot, going and asking the air hostess for a glass of water. Those kind of things are very helpful. Not smoking is a good thing to try and avoid. You get the stockings as well. I don't want to say everyone has to go and purchase them. They're not that expensive, but they can just help with the blood flow as well in the legs. There's not a stocking or anything for here, but for the legs that can be quite helpful. And you can just buy them and use them if, again, you're on a plane. And the same if you're having a surgery, you will get given the stockings from the hospital. That usually, if it's surgery that you've had down in the pelvic area, it's usually up to a month that the surgeons and nurses will ask to wear the stockings and to move around regularly. Thank you. It's a very important question.
Did you find any research?
Yeah, it's working.
Into long-term use of these newer tablets? I've been on rivaroxaban, a high-dose rivaroxaban, for nearly 7 years now. I believe I'm taking it prophylactically at this point. Mm-hmm. I just wondered if you'd found any research into that.
That was what, yes, there have been some, but they're very small studies about how long to use the medication. Because we're worried about the risk of, I suppose, in the balance of another clot, the balance is probably to say it's safer to be on the blood thinner for longer. And I think you're right. It is a prophylaxis now. If we scan, if what you're saying is true, there isn't a blood clot there now, but it's just a way of keeping the blood as in a safe way, as thin as possible, but not too runny. But then the risk of bleeding is there.
Now, I have to say, I have no side effects from taking it. I'm more than happy to take it. I don't find it difficult to take. I'd rather take it than not. Yeah.
And that's a conversation, I think, when we're talking about long-term medications that definitely you can have with your oncologist and hematologist about what you want. And if it is affecting your quality of life, then that might be something you say, no, I do or I don't want to have it. And that definitely should be a conversation that you would be able to have, as long as it's explained to you what we're trying to prevent, which is another clot, versus what the risk could be, which is of a bleed. The risk of a bleed is actually relatively small in these medications. Warfarin was the one which we don't tend to use so much now, where the risk of bleeding was a lot more. And in both the injection and these tablets, we've kind of moved away a little bit more from that risk of bleeding. So we do think about it, but it's much less common now.
Hi, hello. Thank you very much for your talk. Really interesting. I just wanted to say maybe we all have different, or our oncologists have different approach to this topic. And for example, my oncologist, every time we have to fly for a long time, more than 6 hours, I have to take aspirin for 3 days before the flight, during the flight, and after the flight. So I don't know, maybe this is something that is of interest of many others to know what are the different approaches that our oncologists are taking, and knowledge is also
Some
power.
of my patients are take a low dose aspirin anyway as part of their, maybe for other, for maybe they've got cardiac reasons, so that they're taking it. And I certainly would encourage them to take it. And yes, some patients have spoken to the hematologist in my hospital, and depending on the size of blood clot, the time that they had the blood clot, they have been advised either to take or not to take a low dose aspirin. It also depends on the length of the flight as well. I had a patient recently who went to America and had very recently had quite a big blood clot, needed to go, and they were already on the blood thinning. So they didn't need to take the aspirin because they just started the anticoagulation, the blood thinning medication. So there's so many different factors. I would say, yeah, definitely speak to your oncologist about it and see if they say yes or no, why they're, what are their factors, what are their reasons for saying yes or no for each patient.
Hi. Thanks for your talk. I was a bit tardy coming in just now, so you may have mentioned it, but I think it would be quite useful to talk about drug interactions as an awareness, and also food, because, as a patient who's very prone to being very clumsy and hurting herself, things like ibuprofen, we have to be mindful of that. As in not taking it, and also stuff that you eat on a day-to-day basis that you now actually have to pay a little bit more attention to, because as I was spreading marmalade on my toast going, oh, is this made of Seville oranges? And like your juices, it's like, oh, has that got grapefruit in it? Because, these are things that actually impact on how the drug is broken down, and, could cause a slightly higher risk of bleeding, or just, being mindful. And the last thing is also herbal medication, right? There's a lot more supplements nowadays, which you don't want patients to not take altogether, but to understand what they can and can't.
Definitely. So you need to, when you start it should be that when you're starting either the injections or the tablets, that you should be counseled for what is okay to take or not take. And if you want to start a herbal medication, then usually I would run it through. We have a pharmacy because I don't know off by heart the different new medications that you can buy sometimes, even from Holland and Barrett. So we usually do a very thorough check, and it doesn't take long to do. You have the pharmacists within house who can check that and then get back to you, and then it can be. Yeah, so you can easily just check and ask your hematologist about that, for sure. There was a few, I didn't want to miss out.
Hi.
Hi.
I had a question about the risk factors and that Cleveland study that you showed. Because ALK often affects like younger women. I wondered if there's any like hormonal changes, like being in like before your period, after ovulation, or contraception that could affect like clotting and that cascade that you talked about.
It did discuss that in the discussant. Because it was only a small number of patients, there wasn't enough data to specifically say for the ALK patients. But yes, it kind of, again, it's similar to smoking, that smoking is a risk factor for blood clots, whereas smoking and ALK are not, associated. Age is also, and it's not, mutually exclusive, but yeah, younger patients who've never smoked, more common in ALK. So then why is it that then you would more likely to develop blood clot? So they did look at whether there was a link with gender as well. We know that certain types of contraception as well can affect your risk of a blood clot, but they couldn't determine a link just because of the number. So literally it was 2 patients out of 46. Also the timing when the cancer was diagnosed and when the blood thinner was started to when the clot occurred. There's just not enough to be able to, at the end of it, conclude that it was a link. It's just becomes, that's why I was everything I read, and then thought, oh, it's only like 2 patients, and that's why I was getting, not angry, but just, that's why we need more, that's what we need. If we have more patients, more numbers, then only then we'll be able to have a conclusion that this is what's going to happen, or more likely to happen, and therefore let's do this and let's not do that. Like when you were saying about getting a flight with the aspirin, wouldn't it be great if we did a study to say how many patients do take aspirin, how many patients don't take aspirin? Did it affect a blood clot forming? That's the kind of thing we need to do, and that's where the research should be going. Yes.
Yeah, thank you for the talk. It was interesting. One thing you didn't get into was symptoms. So I've had a blood clot, and I was asymptomatic according to phoning the tick boxes. So I phoned my cancer unwell line, and I said, look, my arm is about twice as wide as it should be. But I have no burning pain, I have no spiking pain going down my arm. So they brought me in, and it turned out to be massive blood clots. But what are the symptoms everybody should be watching for or potentially concerned about?
So that is definitely an arm. I'm surprised that I don't want to criticize, if it didn't meet the criteria for a blood clot, but definitely a swollen arm or a swollen leg, even if there's no line in the arm. That would still be a red flag kind of warning sign. Doesn't always need to be red or with the swelling or hot, but in general, a red, hot, swollen limb, arm or leg. More common in the leg, but definitely you can get it in the arm. And it can sometimes go up or down the arm. Can or cannot be associated with chest symptoms. So the breathlessness, short of breath, with or without pain. The textbook things are sharp pain, swelling, the redness, but it's not, I don't want to say very rarely, it's probably actually less common to have all those textbook symptoms, in all honesty. And sometimes we've picked up with very, very small symptoms, or maybe non-significant symptoms, that actually there's a blood clot there. And I think that's the thing, if you're on treatment, if you have cancer and you're developing any kind of different symptom, it doesn't need to be red, hot, swollen, chest pain, then I would be worried. I'm quite, I have a low threshold myself, and I think most oncologists and people who work in oncology, the first number you phoned, were they an oncology team as well? Okay. But the second one was your own oncology team? Oh, okay.
It was the hospital, the oncology ward.
Okay.
So, yeah, I phoned, originally it was phoning radiotherapy team, because I happened to have radiotherapy, and then the next day develop weird symptoms.
Yeah.
I was getting head rushes and things like that.
Yeah.
But then, yeah, I think I left it. It's my own, to some degree, it's my own fault in that I think that idea of developing a new symptom that doesn't make any sense.
Yes. So that's probably a good thing. Yeah, a new symptom that actually you're not quite sure. It could be a blood clot, could be anything, but a blood clot is definitely one of the differential diagnoses, something that needs to be excluded. And then at times that will actually be the diagnosis, but it needs to be excluded. Does that make sense? Yeah. I wouldn't be shy of putting forward the information.
Okay, I'd like to thank Dr. Ghosh on behalf of us all here. There's a little thank you. For
Oh,
that,
thank
just
you.
A small token of appreciation.
That's completely unnecessary. Thank you.
So,